Stand by.
Good afternoon. It's great to be with you today through the satellite video conferencing system. I think the last time that we had one of these scheduled, we canceled it. That was back in April, and last met this way back in January. So we'll try to get back on track with the quarterly satellites. So I'm glad to be here today. I've got several things that I want to share with you. Since we met in January, the legislative session is now behind us. We fared fairly well in that regard in terms of the budget. We ended up having just under a $5 million decrease, and that was an amount of money that we can tighten our belts and absorb, so to speak. But I wanted to talk a little bit more about the broader horizon in terms of what I see as some of the financial challenges that are going to face the agency over the coming months and years. And keep in mind that while none of us have a crystal ball, there are some things that we need to be mindful of. One is the RCO model that Medicaid has put forth and originally had hoped to implement 1 October of this year, 2016. And that model, as you know, is one in which the changing system of financing and delivery of care will be shifted from a fee-for-service model where volume and quantity, the number of services that you do, drives how much you get paid. If you're a health department, if you're a clinician, if you're a hospital, if you're a private physician. And the shift, which follows national trends, is to pay a per head fee, a capitated fee per covered life, here Medicaid recipients, to a coordinating entity. Here again it's the RCO, the Regional Care Organization, and that entity will control who sees the patient. And therein lies the very important component of cost effectiveness while maintaining quality. So the RCO will get a capitated payment per Medicaid covered eligible citizen in Alabama, and that means they'll be looking at the price of different services when they contract with providers to deliver those services. This has some potential to affect the health department, in particular with our care coordination services, less or so with some of the other child health services that we provide to Medicaid eligibles. And so we're mindful of that with the potential that it brings in terms of affecting our bottom line when the RCOs ultimately get rolled out. And that itself is a question. You've probably seen in the papers that the legislature has not yet stepped up to fund Medicaid. The need on Medicaid's part is an additional $85 million beyond what they were given in the budget for 2016, and so for 2017 rather. And so what you see, and this just was announced today, are some of those steps that Medicaid is contemplating in that regard. And what you saw in the headlines was to announce that effective in August they're going to be rolling back sort of an up reimbursement. They call it the primary care bump for doctors who are either internists, family medicine, pediatricians, those folks that do primary care. And that bump is the first of Medicaid's plans, if you will, in the absence of adequate funding to address the shortfall. I think they have said that would save about $15 million out of that 85 shortfall. I say all that to say that as we come to the table and look at our portfolio of services to Medicaid recipients, again primarily in the care coordination arena, we're continuing to look at how to assess our competitiveness from a cost-effective standpoint, how much it costs us to do those services and what we would need to be reimbursed by the RCO. And in addition to that, an important part is what quality, how much of a difference are we making. And our social work staff and leadership continues to invest a lot of time and energy in that, coupled with marketing in general to the probationary RCOs across the state. And as we look for opportunities in a variety of areas, we're starting to see some that are probably moving to the forefront in terms of the level of interest on the part of the RCOs and beyond to the rest of the provider community. And these include telemarketing, which I think current plans for us are to have that telemarketing, listen to me, telemedicine. Includes telemedicine, which I think we're up to about 20 counties now under Michael Smith and his team's leadership in rolling that out with half a dozen different clinical programs where at some level we are starting to move forward in that arena. So I see that as a real potential niche for us over time, be it with RCO or with the other provider community outside of the Medicaid population. The other place that we're exploring is EPSDT, the early periodic screening, diagnosis and treatment model that Medicaid has for well child screenings, if you will. And we used to have a lot more activity in that regard, and we now, over the past few years, have had very limited activity. But that may be an area that we're able, especially when you look at some of the unmet need around provider capacity and access in rural areas, that the health department may identify yet another niche. Those are two examples, and I hope that you're seeing that we're investing a lot of time and energy to try to explore and network and develop the relationships with the probationary RCOs such that we prime the situation as best as possible to be able to continue in some of those arenas. So that's one area that the RCOs, in terms of when I talk about some of the challenges that are facing the agency down the road from a financial perspective. A second one, back to the legislature, I mentioned that we were able to absorb that decreased funding in the general fund for the current fiscal year. But I would tell you that just like with Medicaid funding on the part of the legislature, in general this legislature has not been amenable to wanting to look at new funding sources, be it a lottery, be it how they agree consensus on spending the BP oil spill funding that was recently announced for the state, increasing taxes, just a whole host of things that seem to have been bannered around, but they've really not seemed to have at this juncture the political will to address those, whether for Medicaid or even beyond for the rest of the state agency. So should we continue to face cuts, year in, year out over the next few years on the part of the legislature, that's going to be even more challenging in terms of how we deal with these decreasing bottom lines, so to speak. And, when you look at that, and again, RCO, the funding from the legislature being two of the main challenges, and again, not totally known because nobody has a crystal ball, the question becomes, well, so what do we do about that? And besides marketing and the RCOs, I wanted to share with you a couple of other things that sort of move us in the direction of being able to weather these storms, I think, in such a way that we are able to come out on the other side as intact as possible. And they fall under the domain of what I call realignment or reorganization that is taking place at both the central office and out in the field. I'll cover those separately, but they are related. And as a way of putting this into context, we had, I guess it was Senator Arthur Orr from Decatur, request state personnel to do a review, if you will, of span of control. They called it span of control, but what it really came down to was negotiating on the part of state personnel with a consultant to go in and examine some, I guess, guinea pig state agencies, and they ended up picking public health, revenue, and also corrections. And so the consultant worked with those three in terms of getting, interviewing and getting an understanding of how those agencies operated, and came back with a report around what with some of the thoughts on better structure, if you will, on your management aspect of your agency. And the reason that Senator Orr was interested in this is because as a legislator, and one of those who's a key leader, he would field requests from state agencies for funding, and usually funding tied to personnel needs. And so what was the appropriate kind of staffing model, if you will, that could help guide that process when he received requests such as that? And so we were one of the three agencies that this consultant interfaced with, and the report that came back helped to inform a lot of our thinking and challenge our thinking. But for the central office piece, what it said is that for the state health officer, my position, span of control should be somewhere around 6 or 7 direct reports. And I actually, at the time I came into this job back in November, I had just under 20 direct reports, and that includes maybe a dozen here in the central office, and then the area administrators and area health officers where we had those in place. So we looked at reorganizing the central office structure and have just completed that process. I think you saw the statewide email earlier this week which announced that finalized organizational chart. So now I have 6 to 7 direct reports, and some of the groupings there, some of the moves of some of the programmatic pieces from one area to another on the org chart, all of those were made with a great deal of thinking, brainstorming, analysis, if you will, and I think it's positioned us to be in a lot better structure in terms of moving forward. And I'm not going to get into a lot of the detail, but I want to mention one that we did in this work over the past few months, and that was to create the position of Deputy Director for Field Affairs. And we recruited one of the area administrators, Ricky Elliott, who joined us a couple of months ago in that capacity. And now he directly relates to the area administrators. And I think that that is going to be, and has already proven itself to be, a good move in terms of his primary function being to support the areas in the work that the area administrators lead the area teams to accomplish. And up until this point, there was really a vacuum there. So Ricky now in that position, I think, messages and goes in a significant way in that direction of central office being here to support the work of the field at both the county and the area level, because that is really the foundational piece for this agency to accomplish its mission, in my estimation. So that's all in terms of highlights about the central office realignment that I wanted to share today, kind of give you a 30,000-foot view. I think what's more of interest to you is where are we now on the companion process that's undertaken to address realignment at the area level. And this was actually something that the work was begun 3-4 years ago with a work group, primarily area administrators, to start to look at what better configuration might be for grouping our areas out in the counties into the areas out across the state. And so we were able to really get a quick start, if you will, when we pulled that off the shelf, the work that had been done a few years ago, and revalidated a lot of the analytics and the data that informed the decisions at that time, and have moved forward with this recharged, renewed work group to formulate a proposal to realign the areas. And we earlier today, with that work group meeting, actually blessed an addition of that, if you will, a version of that that's going to be the one that we use moving forward. We have, outside of Jefferson and Mobile, as you know, 9 public health areas, and the map that I signed off on earlier today will realign the areas into 6. 6 public health areas, again, Jefferson and Mobile not in that count. And what I wanted to share with you briefly is a couple of the pertinent points there. One, we wanted to get the map in place by 1 October of this year, and actually we're way ahead of schedule. And I mean, let me say that again. Can you believe we're way ahead of schedule on something? But I guess we moved that up and finished that task today. The second big point to understand is that implementation is to be October 1 of 2017. So the areas are not changing until October 1 of 2017. But you might be asking, well, so why are we rolling this out now? The reason is primarily because we continue to look at what staffing needs are across the state within the counties and the areas, and I want the map out so that it informs decisions around filling positions as we move forward to October of 2017. And an easy way for me to sort of illustrate that is, suppose a program, and I'll pick immunizations as an example, wanted to fill a vacancy in a immunization whatever. Well, I want them to be mindful that they don't need to pick somebody in this county based on our current structure and our current area lines if in 1 October of 2017 that particular county is going to be in a different area. So for people to sort of start to appreciate, that would be a consideration as we move forward with filling positions over time, because we have turnover and we have positions that open up and we have to fill them. So that's part of the reason. The second part of that is because I think it positions us to be better prepared to move through some financial challenges if they unfold in a significant way. And so to have a slow, proactive move towards the new area lines is much better than to wait to the last minute and then it's a Chinese firestorm trying to put all these pieces together and accomplish it, and really that is just fraught with unintended consequences. So there is a second reason that we sort of are moving in this direction at this juncture. It's important to know that just like with the central office realignment, for the field, for the new area lines, I do not envision any rifts. I don't envision any demotions, no loss of salary or anything else. We're going to take advantage over time of attrition through retirements, resignations, those normal day-to-day sort of turnovers, if you will. I think over my career now, since 1990, 27 years give or take, when I started off, I would hear the folks that had been around start talking about, I'll retire in a year or 2 years or 3 years or whatever. And it didn't mean a lot to me. I was like that, young kid out of college and first or second real job. But I'm now on that last sort of phase, that last part of my career, and you look around and you're starting to see folks retiring all over the place. And I know when we talk to the area administrators and they do their reports as they did this morning in the area administrators meeting, that was a common theme. We're seeing more and more retirements. So we're going to look to take advantage of those as we move towards the new area construct. Hand in hand with the geographic lines is the work that is now unfolding around what is the appropriate staffing model for a public health area, and that is also a question, what's the appropriate staffing model for a county level operation. And at the end of the day, we are looking at that being based on business needs. And in times past, when we didn't have so much in terms of financial challenges, certainly ones that are potential for the future, it wasn't as critical for us to base our staffing on the actual business that was being done. But over time and over the next few months, you're going to see a lot more work and dialogue with area and program folks to figure out what the best staffing model will be, so that we've got some metrics, some data, some guidelines, if you will, on what number and what types of employees would best meet the demand in terms of the business before us, whether at the county or the area level. Again, let me repeat that I am not about riffing or laying off, a reduction in force, any of that stuff, unless there is something that compels us to have to do that from a financial standpoint. Therefore, all the more important that we start in a proactive way, planning and taking advantage over time of some of the normal turnover in staff across the state at all levels. So that's kind of where we are on both central office and area realignment. I have a couple other, I guess, comments that I wanted to sort of make, and I think it's important for me to continue to share with you that in this job and having the privilege of being the leader of such a phenomenal agency, you know, there are a couple of things that I remind myself of, I remind my key staff of, and that is I don't believe personally, and for many of you on the team, you can find a higher calling than to want to make a difference in the health of the public, be it an individual citizen or the state at large. And that plays out in so many ways, as I've said before. And it can be that baby that would have been one of our infant death statistics. It can be that baby that had a hearing deficit, and our newborn hearing screening program identified it early, and the baby got referred for the appropriate further diagnostic testing and treatment. And I could go on and on filling in the blank, preventing the unintended pregnancy, treating the STD, controlling a TB outbreak as we did in Perry County, and as you well know, often doing this to a group of folks who are underserved, have kind of been left behind from a socioeconomic standpoint, and that's what public health is all about. So that's the mission piece and the kind of the philosophy of why we do what we do, because you and I both know state employees have not had a whole lot of morale boosters lately. 08 since our last merit raise. Next year, you know, get to 2018, and you're talking about that's a decade of no cost of living raises. You've got the increase in retirement. You've got the increases in health insurance. Asked to do more with less, and in general, it's hard to keep morale up, but I'm a glass half full person. I keep my eye on the prize, and I know that my day-to-day activities and what I can control, which is what I bring to the work setting, that includes attitude, not just work ethic, but what I can control and what I can bring to the work setting that's going to make a difference in the mission of public health is what I continue to hang on to. And I would challenge each of you to try to keep that at the forefront in terms of you going about your day-to-day work and being an incredibly valuable part of the public health team. In that domain, I continue to try to promote this concept of a culture of service. And that culture of service, as you know, is not only to the public, the patient coming in, the restaurant who has an inspection need, the nursing home that we inspect, whatever. The customer is the whole gamut, but customer service is also to your fellow teammate, your coworker. And I would challenge you to not burn up a whole lot of negative energy in ways that are wasteful and productive when you are looking at how you interact with coworkers and as a member of the team, trying to accomplish whatever the task is before you. I see an awful lot of that, and I would just ask that you think about how much negative energy and wasted energy frequently goes into some of those those activities and basically think about how that might not be helpful in terms of getting our work done. The other, I guess, comment I wanted to make in closing is to say how much I appreciate some of the things that have just really struck me as going above and beyond. And I'll use this as an example, staff who have done the work around Zika. And this is, you know, largely some of the folks who are in the tower here in infectious disease and outbreak, but they've carried the lion's share of our work around Zika. And I say frequently, you know, what were we doing before Zika? Because in some ways it has taken over so much of our lives in terms of the time demands. And, you know, this, I start naming names, I'm going to get in trouble, but Dr. Mack and her shop, Kelly Stevens over infectious disease and outbreak, I could go on, but the Zika issue is going to be with us for the long term. And because we're public health, we are in the lead in terms of the state's response to that. We are now up to a count of 9. And CDC, while they recently changed the definition, you know, to bring some that were not on the list into the list, they're in this category called probable. But we're up to 9, and we actually have had the first case that's in a pregnant woman. We knew that was inevitable. There's several hundred when you look across the country in terms of pregnant women who have had Zika infection, and we're on the front end of all of this, but we've had the first one. It was identified today, and the team is doing the appropriate follow-up in that regard. But Zika's going to be here for quite some time. Federal money, federal funding for that is not as timely as we would like it to be, and there's a lot of pressure nationally and from the states to get Congress to move on meeting some of those needs. But again, Zika is where it's talk about a can-do attitude and stepping up and moving forward with doing what needs to be done. Say the same thing about the Perry County outbreak. A more recent example was the EPA announcing the new water advisory on the PFCs. It affected several water systems in the northeast part of the state, and you know, Dr. Garisco, our state toxicologist, Dr. Mack, Dr. Harris, the whole group of folks that just say, step up to the plate and how can we move through this as well. ADPH had a significant role there, as did the Department of Environmental Management, because it was assigned to us to determine on the basis of the health advisory from the EPA how far we wanted to message some of the educational pieces and recommendations. So putting all that together and rolling it out in an environment that's highly charged from a political, you know, and a patient fear, a public fear kind of perspective was something that we moved through, and it was another example of where folks step up to do what needs to be done. So that really concludes my remarks today. I guess, are we going to open the phone lines for questions?
We don't have any emails or phone calls at this time.
Okay. That was 30 minutes already? I've been talking?
It was.
Okay. So, well, we're going to give it just a few minutes for questions. So, nobody in the audience has any questions? All right, so I've been in this job since November. Is that 8 months? Have I hit my 1 year yet? 8 months. That has flown by. Nothing? All right, well, I'm not going to hold you up, and what I want to do is close by telling you how much I appreciate each and every one of you, and I hope that you have a good rest of the week.